All right. So this week we are covering disorders of the digestive system. So I thought today we would start out with a brief kind of overview of the digestive system. I'm sure you guys have covered this already, so it shouldn't be much more than just a review for you guys. So let me start by asking you, where does the process of digestion begin?
The mouth.
In the mouth. And what are the two processes of digestion? There were two ways that food is digested.
Chemical and mechanical.
Excellent. Chemical and mechanical. So what is the mechanical part of digestion?
The chewing.
Chewing. What is the medical name for chewing?
Mastication.
Mastication. Very good.
Mastication. I forgot.
Mastication. What is what other organ is responsible for mechanical digestion?
The esophagus.
Stomach.
Oh.
The stomach. So as the food is resting in the stomach, it has smooth muscle wrapped around the stomach in different layers so that the stomach can continue to churn and grind the food around. So we said esophagus. So we know the esophagus is the tube that food travels down. What is the name of the rhythmic wave-like motion that we use to propel food down the alimentary canal?
Peristalsis?
Peristalsis. Peristalsis. And the next thing that I was going to ask, what is the difference between the pharynx and the larynx? What's the difference between the pharynx and the larynx?
Isn't the larynx the voice box?
Yes.
And the pharynx is a tube?
Is a tube, yes. Can we get a little more detail?
Okay, so it says the epiglottis keeps food from entering the trachea. So it's right before the trachea, like right where the pharynx and the larynx is. Okay.
Yes. And so if it starts down by the trachea, yes, by the epiglottis, how far upwards does it extend? It goes up to the back of your nose. You guys ever got one of those, like when you're congested, right? And you get one of those like snot globs back here and you gotta like and pull it back from the back of your nose down back your throat? That's the pharynx. That's your pharynx. So from the back of the nose down to the back of the throat, down to the epiglottis, where we either have to decide to go towards the lungs or you gotta decide to go towards the stomach. So kind of think about the pharynx as like your throat. That's like where you're hocking the loogie, back behind your nose and down in the back of your throat. That's it. The larynx is a cartilage structure that sits in front. That's the voice box. That's where your vocal folds are. Good stuff. Good stuff. All right. So we said the stomach is where the mechanical digestion happens. Where chemical digestion is going on here. What are the main secretions of the stomach? Do you guys know what the two main secretions are in the stomach?
Mucus and acid.
Mucus and acid. Oops. Can you tell me what kind of acid the stomach mainly secretes?
Hydrochloric?
Hydrochloric. HCl. Hydrochloric acid. In its pure form, hydrochloric acid has a pH of 1. That stuff is strong enough to clear like oil off your driveway. That is heavy duty stuff. So where the acid is trying to constantly eat away at the inner lining of the stomach. Your stomach, much like your skin, has layers that are growing up from the bottom. So the innermost layer is almost dead and sloughing off. There's also a mucus layer that coats the inside of the stomach and protects it. Moving on to small intestine. There were 3 sections of the small intestine. Can we name them? What were the 3 sections of the small intestine?
DJL or whatever, DJ.
Yes! DJ Ill. Dropping the poops. DJ Ill. Duodenum, jejunum, ileum, in that order. Duodenum, jejunum, ileum. So if the stomach is focused mainly on mechanical and chemical digestion, right? Breakdown of the food. We then pass the food through the pyloric sphincter into the next section of the tube, which is the jejunum of the small intestine. I'm sorry, the duodenum of the small intestine. The duodenum is still breaking down the food. There's still like digestive action going on. The jejunum is where absorption is taking place. Ileum, we are still absorbing our nutrients. By the time we then pass through the ileocecal valve into the large intestine or colon, that was a terrible N. First question, what were the sections of the colon, the sections of the large intestine?
Ascending, transverse, and descending?
You're on the right track. So when we first enter the large intestine, do you guys remember the entrance pouch, what that portion is called?
The
Here's a clue.
cecum?
The cecum, there we go. That was also terrible. Sorry, my handwriting is so horrible, you guys. The cecum. So we pass through the ileocecal valve into the cecum. Once we are in the cecum, we have a choice. We can either head downward inferiorly, and we head into a structure called the appendix. But if we decide instead of heading inferior, we head superiorly, what structure do we find ourselves in now?
The ascending colon.
The ascending colon. After that, we have the
Transverse.
transverse colon. After that, we have
Rectum.
not yet.
Descending.
Descending colon. Then
Sigmoid.
sigmoid. And then finally we have
The rectum.
rectum. There we go. By the time food reaches the large intestine, the vast majority of the nutrients have already been absorbed. What was one of the primary functions of the colon? What was its job?
To absorb water.
Absorb water, maintain the water balance. Very good. So by the time the food gets to the end of the large intestine, right, the end of the large intestine, all the usable nutrients have been extracted. All of our local bacterial friends have had their fair share. We've extracted all the usable water. So whatever is left over is a waste product and it gets flushed. What is the role of the liver in all of this? The food never like passed through the liver. So what's the liver, what role is the liver playing in digestion?
It produces the bile.
Bile. And bile functions to do what?
Break down food.
fats.
Break down fats. So bile is produced in the liver. Where is it stored?
Is it the appendix?
Not the appendix,
The gallbladder.
gallbladder. In the gallbladder. So when the gallbladder is full of bile and the digestive system decides that we need some of this bile, where does the gallbladder kind of secrete that bile into? Where does the bile go? Here are our options, right? We had the stomach, we've got the sections of the small intestine. Where does the bile go?
Small intestine.
Small intestine. Do we know where precisely? It is the small intestine, but do we know where? Take a guess. It's 1 in 3.
I'm gonna say jejunum because it's stomach juice and it makes sense.
All right. So we said in the stomach, we're still breaking down stuff, right? We're still digesting. In the duodenum, we're still mostly doing the digesting stuff. So this is where it goes. The jejunum is doing mainly absorption. By that point, it's mostly digested, it's mostly broken down. So the jejunum and ileum are more about nutrient absorption. Duodenum.
So no stomach juice for the other two. Gotcha.
What other functions does the liver serve?
Processes toxins.
Processes, I'm sorry, say that again.
Toxins.
Yes. Oops. What's the most famous toxin that our livers have to metabolize?
Alcohol.
Alcohol. Yeah. All right. And last one that I would want to talk about is the pancreas, since we're talking about digestive organs. What are the 2 main hormones that the pancreas produces?
Insulin.
Insulin, number 1.
Is it glucose or like glucagon?
Glucagon.
Gotcha.
And each of those has to do with blood sugar. So insulin lowers the blood sugar, glucagon raises the blood sugar. So we just keep producing both of these so that homeostasis is maintained. Very, very good, you guys. Very good job. All right. So tonight, we're covering digestive system disorders. So we've got a variety of conditions that we're going to look at. The first one that we're going to start with, when I looked at all these disorders, I figured I would just kind of start at the top of the digestive system and kind of work our way down. So the first ones we're looking at really kind of affect like the esophagus and stomach, and then we move into diseases of the small intestine, then diseases of the large intestine, and then we'll go back to the accessory organs. We'll look at the liver and the gallbladder. I just figured that that layout kind of made a little more sense. So the first one that we'll look at are gastric ulcers. Gastric ulcers, you will also hear them called peptic ulcers. They are called gastric. The root is gaster or gastro. That's referring to the stomach. That's where they typically occur. but peptic refers to pepsin, which is an enzyme in the stomach. It's used to digest proteins. And this is the one that, since it's a protein digesting enzyme and your whole freaking body is made of proteins, once the ulcer starts, the pepsin is really what's irritating it. So those are peptic ulcers, but they are also gastric because of where they are located. So peptic ulcers.
Is
Go
there
ahead.
any relation to the product Pepsi by chance?
I don't think so. I do not think so. Although that would be a really interesting question. Pepsi. Where did Pepsi get its name?
Yeah, because it definitely messes with my stomach.
The word Pepsi comes from the root word dyspepsia, which means indigestion. This healthy cola continued to thrive into the dawn of the 20th century, and in 1902, the Pepsi Cola company was formed due to the syrup's demand.
Almost.
Yeah, so yeah, we're getting there. So now my question is, what about dyspepsia? From dyspeptos, difficult to digest. All right, there you go. Fun stuff. Fun stuff. Okay, so gastric ulcers. Etiology of this is that there is an open wound in the stomach lining. So let's just take a moment and imagine we've got all of those layers of soft tissue, right? Epithelial tissue, and there's a mucus lining on the top, but the mucus lining has become eroded. The stomach acids are burning into your flesh of the stomach, and the enzymes, the other digestive enzymes, which now have access to it, start doing their thing and start breaking down the proteins. Generally, what we see with the infections here is the presence of a bacteria. So peptic ulcers have this long history of being associated with stress. And I'm sure your grandparents will tell you, like, oh, don't stress out, you'll give yourself ulcers. Generally, what they were witnessing was a correlation between stress and people erupt with ulcers. Nowadays, we understand that the root cause of them is oftentimes a bacterial infection. The bacteria is Helicobacter pylori or H. pylori. And the reason that the ulcers tend to flare up during times of stress is because times of stress tend to inhibit your immune system, and that allows the bacteria to thrive. And then when you go into a non-stressful period, your immune system bounces back and you get the infection under control. So the ulcers, clear up. Other things that can cause them are heavy NSAID use. So people that take a lot of Tylenol or ibuprofen or Aleve, things of that nature, they tell you not to take too much of that stuff because ibuprofen and naproxen can be really hard on your stomach lining, but you want to be easy on the acetaminophen, the Tylenol as well, because Tylenol can be really hard on the liver. So acetaminophen takes a lot out of the liver for it to be metabolized. So signs and symptoms of ulcers, you'll usually feel a burning, kind of a gnawing pain right in the center, right in like the top center where the stomach is located, right where the ribs come together. Pain, but it gets better after eating because the concentration of material in the stomach is now less acidic. So when you eat food or drink water, it gets a little better, but as that food digests and passes out of the stomach, it starts to get worse again. So again, contributing factors, we would talk about stress, but again, it's not stress itself, it's stress's effect on the immune system, which is allowing this bacterial infection to thrive. Aggressive factors recover more quickly, thus leaving lining vulnerable to acid. Again, Helicobacter pylori, H. pylori is the bacteria. So when someone has ulcers, some of the complications, the further problems that can arise, well, number one is anemia, because you have an open sore in your stomach, so you're bleeding. So there will be some blood loss that can lead to anemia. Another risk is perforation, so that the ulcer eats all the way through the stomach, and now your stomach contents start to leak out into the guts. So you start to leak food and digestive juices and all that nasty stuff, and you can imagine how crazy that would be. Your body treats it like an infection, so you got to go to the hospital. Oftentimes, people also get stomach cancer. This is oftentimes due to the fact that the stomach tissue is getting damaged and it has to heal, and then it's damaged and it has to heal, and it has to do that much more often than usual. And when cells have to reproduce more times over their normal lifetime than they usually should, cancer tends to step in. It just has to do with the degradation of the copying of the DNA over and over and over again. Errors also get faithfully copied over and over. So too many DNA copies, you'll start to degrade the DNA, and it can lead to cancer and other forms of breakdown and disease. So if your client has peptic ulcers, they're usually contraindicated for deep abdominal massage. They're usually very uncomfortable, so they don't want to have them poked at. Otherwise, massage is helpful to decrease the stress. Not really too many considerations other than, if they're having kind of a flare up, you just may want to be a little more gentle on the abdominal massage, and maybe be a little more gentle on the tapodiment on their back, because you don't want to go vibrating their ulcer around. All right, good stuff on ulcers. Good stuff. Next, we have gastroesophageal reflux disease, or GERD, also known as simply reflux. Now, everybody gets acid reflux from time to time, particularly when you eat, really acidic foods and things like that. But some people suffer from reflux a lot more frequently. And because of the constant upflow of gastric juices, and they're really acidic, they'll start to eat away at the inner lining of the esophagus, and this can lead to GERD. Now, usually the cause can be a weak esophageal sphincter. So the sphincter between the esophagus and the stomach, which when I was taught anatomy, now this may have been, 150 years ago, but when we look at the stomach, let's see, there we go. When we look inside the stomach at the top, the sphincter up here is called the cardiac sphincter. That's the sphincter between the esophagus and the stomach, the entrance to the stomach. It's called the cardiac sphincter because it sits right up next to the heart. That's also why reflux is called heartburn, because the two are located right next to each other. On the inferior side, between the stomach and the small intestine, you have the pyloric sphincter. Pyloric sphincter is the exit to the stomach and the entrance to the small intestine. So if the esophageal sphincter is weakened, then it doesn't take much, remember, because the stomach is moving itself, right? It's moving and churning. So it doesn't take much if the sphincter is weak to allow a little bit of that digestive fluid to backtrack into the esophagus. And if we think about it, remember, the inner lining of the stomach is uniquely designed to handle that kind of acid. The esophagus, on the other hand, is not. So heartburn happens occasionally. GERD happens more frequently and leads to damage. Another common issue that can cause GERD is an issue with the esophageal hiatus. The esophageal hiatus is this hole here in the diaphragm. Wait, not that hole. There's that hole. So here's your esophagus, and it has to pass through the diaphragm. So the diaphragm itself will have several holes in it. The esophageal hiatus is the hole that is for the esophagus. You can also see the other hole up there at kind of your 11 o'clock position. That is the hole for the inferior vena cava to head up to the heart. So if the diaphragm muscle has been weakened, or if that hiatus is damaged, and maybe the hole has been overstretched or something like that, or you could have just been born with a defect there, it can damage that sphincter area, and then we can lead to backflow of the gastric juices. So the number one symptom is obviously going to be heartburn. People burp their stomach contents. You've got like an acid taste in your mouth. Again, as the acid washes over the esophagus, those tissues have to heal. Prolonged damage to them can lead to esophageal cancer. And GERD can occur from anyone, from infants to the elderly. One detail that I would add to the esophagus, since we're talking about it, let me get my esophagus kind of isolated here. When we look at cases of esophageal cancer, when the cancer occurs in the distal portion of the esophagus, generally we find that due to GERD, right? Due to reflux disease and things of that nature. When we find esophageal cancer that's more on the proximal end, those cases are usually due to smoking. So we can see a delineation of where the cancer occurs based on etiology or based on cause. That's all. Okay. So lower esophageal valve dysfunction, as we said, a lot of different things can lead to this. Pregnancy can cause it because as the baby grows, it pushes up on the diaphragm. All of your internal organs are going to have to shift and shuffle around to make room for that baby. Obesity puts extra strain on the rib cage and puts extra pressure on the diaphragm. Smoking, as we said, certain foods, really fatty foods, really spicy foods can cause reflux. Other types of connective tissue diseases, Marfan syndrome is one that comes to mind. All the connective tissues become damaged with Marfan syndrome. One of the more famous cases of Marfan was a female basketball player, like 6 foot tall, super athletic. And she was in her like 20s or 30s. She was really, really young playing basketball and her aorta just exploded, like Marfan syndrome or Marfan disease. So other complications of GERD, this can lead to respiratory injury, particularly if the stomach juices aspirate into the lungs. You can just imagine how delicate that lung tissue is when it comes in contact with that super acidic stomach acid. Lungs tend not to fare well in those cases. This can also lead to ulcers in the esophagus, right? Open oozing sores in the esophagus, as well as stricture. Let's pull this up. Stricture is a restriction on a person or activity. I think there's probably the better picture. It's up in the corner there where the esophagus is inflamed due to damage, but now it's almost closed, so it prevents food from getting to the stomach. So clients with GERD, generally we want them to wait a couple of hours after they eat just to make sure that all of the stomach contents have moved on into the small intestine, so there won't be anything for them to regurgitate. You may also need to put a pillow over their head and kind of incline them up a little bit. The idea is you want the esophagus to kind of be inclined uphill. So if there is anything, it has to go uphill to get up to the mouth. We can also do chair massage. That's also perfectly fine. All right. Another common one, especially today, we're seeing cases of this one rise, is Crohn's disease. So Crohn's disease is going to be a chronic inflammation of the GI tract. So the inner lining is being attacked. Generally, we associate it with autoimmune. However, we think that some people just may be genetically predisposed to it. We also think there may be bacterial factors at play, like there may be a bacterial infection, or that the inflammation is an immune response to the presence of a certain bacteria. So maybe the immune system is going overboard with it. So Chronic inflammation of the GI tract and sometimes beyond. So anywhere along the GI tract is fair game for Crohn's disease. This causes abdominal pain, a lot of cramping and diarrhea, bloody stools. I think the diagnostic criteria is you have to pass like multiple bloody stools per day. It's rough and it's painful. Usually onsets in the 20s and the 30s. And as you can see in the picture, right, you don't have like a nice, smooth, pink digestive tract. Instead, it's become inflamed with these kind of cobblestone-like lumps. So it is progressive, which means it's going to get worse over time. It results in patchy inflammation. The whole GI tract is fair game. So everywhere from the esophagus to the rectum, anywhere along that tube. There are three main kinds of damage that Crohn's disease can cause. And the first of which, and probably the more prevalent, is just inflammatory damage. Right, inflammation in the short term is very beneficial. It helps, reduce blood flow to the area. We can, or increase blood flow to the area. We can get white blood cells involved and get the whole immune response going on. Inflammation becomes more damaging the longer it goes on. So when you have, chronic inflammatory diseases where you're having inflammation that's persisting for weeks or months or sometimes years, that kind of damage can be cumulative and it can be severe. Fistulating damage, which we'd also perforating. So we've got damage where the wall has actually been eaten through and now whatever is in can now leak out, as well as stenosing, which is a narrowing, right? Based on the same kind of thing as we saw with the stricture. The intestines become inflamed and the inflammation narrows their lumen and reduces the ability of material to pass through the intestine. And the biggest challenge with treating Crohn's disease is we don't really know what causes it. So we really don't have a way of treating the cause. All we really can do is manage symptoms. So we can put them on anti-inflammatories or usually really strong steroidal anti-inflammatory steroids. But for massage considerations, we can help them relax, right? Relaxation always helps the immune system. That improves their moods and decreases stress. But we want to avoid deep abdominal work. They probably will not request deep abdominal work because their guts are very sensitive and they're always crampy and bloated. If they're having an acute flare of Crohn's disease, like they're actively going through the pain, we probably would just avoid massage altogether. So somewhat similar to Crohn's disease is ulcerative colitis. There are a few key differences. The first of which, ulcerative colitis presents as shallow ulcers that are very widespread. So it's not small patches of inflammation, whether it's more of a carpet of an ulcer spread throughout a larger area. The name ulcerative is telling you we have an issue with ulcers, right? Colitis is telling you inflammation of the colon. That is also an important clue here. Ulcerative colitis is contained to the colon. It does not spread through the small intestine or the stomach or the esophagus in the same way that Crohn's disease can. It's almost always located in the rectum, ulcerative colitis, almost always in the rectum. So you can imagine you're passing fecal matter through the rectum on top of open, painful, oozing ulcers. Is no bueno. Diagnostics is multiple bloody stools in a day, like 10 to 20 bloody stools per day. And there's painful abdominal colic. If you're not familiar with the word colic, it's abdominal pain. It's usually related to digestion or gas or bloating. I'm sure, ladies, you've heard of colicky babies. Same, that's what we're talking about. It's just abdominal pain. But super bad, crazy, intense abdominal pain, and it bleeds every time you poop, and it's awful. Ulcerative colitis is thought to be caused by an autoimmune attack of the colon. So it's your own immune cells that are going ham for whatever reason. And again, because they're suffering prolonged, sustained inflammatory damage, these people are at a higher risk of colorectal cancer. Remember, if you've got cells that are having to regenerate more often than usual, those cells typically become more prone to cancer. So for ulcerative colitis, massage is indicated, but if they're having an episode, we want to avoid the abdomen. Again, you shouldn't go pushing on somebody whose problem is they have bloody stools. Let's not be pushing on their abdomen. I would also let the client know where the bathroom is ahead of time, just so they know if they need to make a beeline, they know what direction to head in. So again, Crohn's disease versus ulcerative colitis. Crohn's is going to have patchy ulcers, right? So they'll be, grouped in a few areas, kind of spread out around the system. Surgery may help, but surgery, it's just going to delay it, right? You still are going to have a digestive tract, and you can still develop inflammation anywhere along that digestive tract. Since ulcerative colitis is restricted to the colon, and it's almost always contained to the rectum and the descending colon, then surgery is usually successful in treating it. They just remove the colon. And you can't get ulcers on an organ that you don't have. So if they take away your colon, you don't have ulcerative colitis anymore. Good stuff? Good stuff. All right, gastroenteritis. Gastroenteritis, the name is telling you this is an inflammation of the inside of the stomach. So an inflammation of the inner lining of the stomach. Side effects include nausea, vomiting, diarrhea. There's colicky abdominal pain caused by cramping of the bowels. Usually it doesn't require treatment. Gastroenteritis will resolve itself. But oftentimes people think that they have a 24-hour flu instead. So sometimes you'll get misdiagnosed. Usually the cause is viral, particularly Norwalk virus. Norwalk virus is very contagious, and it's usually passed through the fecal-oral route. So number one, make sure you're really checking out your sexual partners, but also it can be foodborne, particularly in less developed areas. If there's fecal contamination in the water source and we're eating food like shellfish out of fecal contaminated water, then you can get it from shellfish. You can get it from other kinds of food poisoning, like improper storage and handling of food. If this is why like food has to be kept at certain temperatures. So if your shellfish get too warm, parasites can also cause it. Parasites like Giardia, Giardia is found in contaminated water, like rivers and streams. The main danger with gastroenteritis, because it causes a lot of vomiting and diarrhea, the main issue is dehydration. That's usually what's going to do the most harm, especially for children and the elderly. So just push fluids. They likely won't seek massage because they feel really sick. But again, with common sense, massage is contraindicated because they have like a system-wide kind of infection, and it may be viral, it may be contagious. So I would reschedule the appointment. All right, next up is irritable bowel syndrome. So IBS, it's a functional condition of uncoordinated peristalsis. So when we say a functional condition, what we're saying is it's not an infection, right? The problem is your own body isn't working the way it's supposed to be working. The peristalsis action, where we coordinate these smooth muscle contractions to keep food propelling through the system, peristalsis starts to become uncoordinated. And so food doesn't get passed like it's supposed to. So one of the main symptoms is alternating constipation and then diarrhea. So like for 4 days, I cannot get off the toilet. And then for a week, I cannot do anything on the toilet. Sudden urging to go, stool under stressful situations, pain, abdominal cramping. They'll diagnose IBS by exclusion. So once they've ruled out everything that they can test for, and IBS is functional, it's not structural. So there's no disease present, right? You don't have an infection that we can fight. Antibiotics won't work on this. You just have a hyperreactive bowel, and your peristalsis is more of a spasm and uncoordinated rather than a nice flowing, smooth muscle contraction. Symptoms can resemble more life-threatening disorders. One of the more worrisome is colorectal cancer. But again, we can test for colorectal cancer and we can test for ulcerative colitis. They can just put a camera up there and look and see if you have colitis. Same with Crohn's disease. They can do ultrasounds and CT scans for appendicitis. So we have ways of ruling out all the other more serious things. One thing though with IBS is that it does tend to overlap with chronic fatigue syndrome and with fibromyalgia. So we're not sure why some of these diseases tend to be comorbid with each other. We have some ideas, maybe they're autoimmune, maybe it has to do with a gut flora imbalance that's leading to a cascade reaction through the body. But until we get better studies, we're still just not really sure. We just notice that these diseases tend to be comorbid with each other.
Dave,
Yeah,
can it be temporary or is it considered kind of a permanent disease?
IBS.
Yeah.
From my understanding, we can't really treat it. So I'll double check, but my understanding is that it's just chronic. Some individuals may have, bouts and spells or something, but
Yeah, it says IBS is a chronic condition that you'll need to manage long term.
yeah, treatment can help, but this condition can't be cured. Chronic can last for years or be lifelong. So yeah. So massage considerations for IBS. It is well indicated. Massage is indicated for IBS. It helps relax and reduce stress, which can be triggers for IBS. But oftentimes the abdomen is too tender to touch. So again, with most GI issues, abdominal massage is going to be contraindicated, except for like constipation. That's like the one where you got a solid pass on it.
Mhm.
All right, so moving on to the liver. Here we have cirrhosis of the liver. What's happening with cirrhosis is that your healthy liver cells, right, your healthy hepatocytes, are slowly being outnumbered by scar tissue. And a little bit here and there isn't so bad, especially for the liver. Of all of your body organs, you guys, the liver is by far the most resilient. It can bounce back from a lot of stuff. Not only can it fully regenerate itself if cut, which none of your organs can do, right? If you cut off half a lung, you have half a lung. If you cut off half your liver will regrow. And liver has lots of redundancies built into it, so it can just keep trucking along and doing its job. So with cirrhosis, it's really, really bad before you start seeing symptoms because the liver is just so darn good at its job. By the time you start seeing symptoms of cirrhosis, the majority of the liver has already been subsumed with scar tissue. And I shouldn't have to explain it, guys, but scar tissue is not the same as liver tissue. The liver cells need to do their jobs. Scar tissue is going to be mostly collagen, right? The same kind of scar tissue we're used to seeing. It does not get to do the same fancy stuff that liver cells get to do. So liver function starts to become impaired. And again, by the time it's bad enough that you start seeing symptoms, the cirrhosis is usually pretty far gone. The reason that scar tissue is being laid down in the liver is due to irritation and inflammation. So one of the first symptoms that you'll see is jaundice, nausea, weight loss, intra-abdominal edema, which is again a fluid swelling, but of the abdomen. And hepatomegaly, which is an enlarged liver. It's physically larger. You can usually see it kind of bulging out of the upper right quadrant of the abdomen. So cirrhosis, there you can see that abdominal swelling. This is called ascites, the abdominal swelling. Cirrhosis can be caused by a lot of different things. Most commonly, it's caused by alcohol abuse. And I don't mean like, a glass of wine with dinner type of thing. I'm talking about the I know what time the liquor store opens kind of alcoholic. We're talking about long-term functional alcoholism, chronic sustained alcohol damage to the liver. We're not talking about like your weekend warrior type, quarantini type people. We're talking about functional alcoholics here. Other things that can lead to cirrhosis of the liver are hepatitis B and C. These are both viruses in the blood that affect the liver, as well as gallstones. If gallstones are blocking the flow of bile, then bile can start to backtrack into the liver and it starts shutting things down. So some of the complications with cirrhosis would be portal hypertension. When we talk about portal hypertension, there is a very fancy blood supply that goes to the liver. So if we see how the liver has one of those special ligaments, so it really like wraps on to a blood vessel. Oh, that's not it. What am I looking for? I'm looking for the portal artery. It's here somewhere. Oh, that's not what I'm looking for. I'm looking for the portal vein. If I could find it on my anatomy app, would be it. So remember, guys, your liver has a lot of crazy important jobs to do. And one of them is it's collecting a lot of the blood, the venous blood from your intestines, which now that venous blood has a lot of nutrients in it. So the liver is going to help break down certain nutrients, store certain nutrients like glucose. Your liver will store a lot of glucose as glycogen for later. So we have sugar stored in the liver. So the liver has like a very extensive artery and venous network within it. And so if the liver is becoming enlarged and it's becoming subsumed with scar tissue, then this can start to increase the blood pressure within the hepatic portal. If they have ascites and they've got all that fluid swelling, that can start to result from the backup of the blood that's trying to get into the liver, right? The liver's clogged, so the blood starts to backflow. And once that blood pressure and the fluid pressure is off, now the interstitial fluid can't get retaken back into the capillary. So it's stuck as interstitial fluid. It can't become blood plasma again like it wants to. So now we've got all this fluid swelling. So if their cirrhosis is mild and there's no edema present, then massage is fine. But if the cirrhosis is more advanced, if they have the fluid swelling of the abdomen, ascites, massage is contraindicated. The circulatory system is being taxed enough. Do we have any questions over anything we've gone over so far, guys?
What did you say that advanced stages is? Like, what would we be looking for, like, or would they just know that and tell us?
Well, they would certainly know. Yeah, they would certainly know. But the abdominal swelling is called ascites.
That's when you don't do massage.
Correct.
Just locally or at all?
I wouldn't do circulatory massage at all.
Because then they're going to have like low platelets and stuff in their blood, and you're just going to get it all mixed up and going all over their body.
Well, their circulatory system is being taxed, right? Because the liver is creating a stop gap in the flow of blood. So everything's getting backed up. That's why there's fluid swelling. So if you go increasing circulation, you don't want to increase circulation when there's already a dam blocking the river, right? You're just gonna create more fluid swelling. It's not gonna help them.
When you see people with big stomachs like that, is that always going to be the case that they, you know, have cirrhosis or they're alcoholics, or is there other
Not
reasons people would have?
Not always. There are other diseases that can cause an enlarged abdomen. Cushing's, I believe, is the one that I'm thinking of. Yeah, weight gain around midsection. Cushing's disease is an endocrine disorder, and it causes a lot of weight gain right in the middle. So you'll see there, like, it looks like they've kind of got a bulging stomach. And you'll also see stretch marks. And so you'll think, like, here we go with Cushing's. So you would see the bulging stomach and you would see the stretch marks. And what a lot of people do is they'll think, oh, see, there's the fluid swelling, right? It swelled so much that it stretched the skin, thinking cirrhosis. That's endocrine. That's all endocrine, right? The weight gain around the face, right? But notice how, like, there isn't a lot of fat around the arms.
Yeah.
And the picture doesn't go down, but there's not a lot of fat along the legs either. It's really like there's a cartoon of it. Like it's really concentrated in the midsection.
Okay.
So the answer to your question in short is no, there could be a lot of different things that are causing this.
Okay.
All right. Next up, we have viral hepatitis. One of the first signs of hepatitis is jaundice, and that's what you're seeing here, a yellowed condition caused by the presence of a product called bilirubin in the blood. Normally, bilirubin is filtered out by your liver, but again, hepatitis is inflammation of the liver. So if the liver cannot do its job, this bilirubin starts to backflow into the bloodstream, and it permeates the skin like your blood tends to do. And bilirubin is heavily pigmented, so you end up looking like a Simpsons character. That's not a color adjustment on your laptops. He really is yellow. The whites of your eyes, right? The whites of your eyes will also turn yellow. The whites of the eyes are called the sclera. So a yellow of the sclera. It's one of the diagnostic traits. So hepatitis is liver inflammation, and it's caused by a virus. Symptoms include jaundice, fatigue, abdominal pain, nausea, diarrhea, enlarged liver, right? Because it's inflamed. And hepatitis generally comes in 3 main flavors. If you absolutely have to contract hepatitis, you want hepatitis A. That's the easiest one. It's not super, I mean, it's infectious, but it's not super bad. You get an acute infection, no lasting symptoms, right? You get an infection and it clears away. It's usually caused through oral fecal contamination, contaminated food and water. And there is a vaccine for it. If you can get a Hep A vaccine, it's 1 shot and it's done. So if you have to get hepatitis, you want hepatitis A. Hepatitis B is a little more serious. This is going to develop into a long-term chronic infection. 5% of people develop chronic liver disease. It's often contacted through shared fluids. So again, hepatitis is a blood-borne illness. So we have to be thinking about ways that body fluids can become contaminated. So sharing drug needles, sharing tattoo needles, unprotected sex. If you're really into like kinky blood play, that kind of weird stuff, like just don't share blood with folks, guys. Now, the good news is there is a vaccine for hepatitis B. You have to take a shot. It's 3 shots over 6 months, and then you have to do that every like 20 years. But there is a vaccine for it. Hepatitis C is the strain of hepatitis that you absolutely do not want. It is also a long-term chronic infection, but you may not show symptoms for decades. 85% of people will develop chronic infections with risk of cirrhosis. It's also, just like Hep B, it's also caused by shared fluids, so tattoo needles, drug needles, unprotected sex. And there is no vaccine for it. Hep C is pretty serious, and it can lead to other complications, especially if you have other kinds of illnesses. Hepatitis C poses a grave risk for people with compromised immune systems. So anyone who has had a transplanted organ, anyone who has autoimmune issues, anyone who has HIV, hepatitis C is one of the opportunistic infections that can arise. So whether massage is contraindicated for hepatitis is going to depend on like which hepatitis they have. If they have hep C, right, if they're not actively sick, you're not likely to contract it, right? As long as you're doing massage the proper way. Now, if you're sharing blood with your clients, what you're doing probably isn't massage. So, but if they have an infection or if it's in its acute phase, it's contraindicated. If there's edema present, we would avoid circulatory massage. If the infection is resolving itself and it's going away, then massage is fine, but I would still avoid the area and go really easy around the liver. Hepatitis really targets the liver, so it's going to be really sore. And next up, we have gallstones. Oh, goodness. Aren't those lovely? High concentrations of cholesterol, fats. High cholesterol in the blood precipitates into the gallbladder and it starts to crystallize and form stones. It is very normal for these guys to be present. You could have gallstones for decades. You'll never know they're there. They won't cause you any problem. They are no big deal until they get stuck in a duct. And that's when you start to have a problem. Because the main duct in the gallbladder is the common bile duct. And it's responsible for transporting, wait for it, bile. That was too much. There we go. So the gallbladder and the liver are both transporting bile using the common bile duct into the duodenum of the small intestine. And so with gallstones, like I said, you'll have gallstones in the gallbladder for months or years, no big deal, until they get lodged in the duct. And now the duct starts to become inflamed. There starts to become a backflow of bile. So the vessel starts to become distended and swollen with fluid. This is more common in females who are overweight, who are fair-skinned, and who are within childbearing age. We get, since the liver's in the upper right quadrant, we get pain in the upper right quadrant. It radiates up to the right scapula. The pain is worse after a high-fat meal because remember, the presence of fat in the digestive tract will stimulate the production of bile. So we send the bile down the tube, but the tube is blocked. So every time you eat fatty foods, we unleash more bile and it swells that vessel even more. Contributing factors include estrogen, pregnancy, decreased gallbladder activity like fasting, cholesterol lowering drugs, rapid weight loss. Several things can cause gallstones. Most gallstones are silent. No issues, no pain with them. Liver can refer pain up to the right scapula and up into the right side of the mid-back. And the pain can be intermittent or constant, just depending on how bad the stone is, how large it is. There is a risk of pancreatitis and peritonitis if the duct is blocked. Peritonitis is, let me see if I can show you guys. I don't think it shows the peritoneum. I don't think it shows the peritoneum, but all of your abdominal organs are held in a sac. It's a double fold of fascia that surrounds all the abdominal organs and just holds them in place. If the bile escapes and it starts leaking out into the tissues and it comes in contact with the peritoneum becomes inflamed. That's peritonitis. So if there are no symptoms of gallstones, then massage away. There's really not much you're going to be able to do that will aggravate the condition. But if there is a gallstone flare up, they will not seek out massage. If you've ever had a gallstone, I don't know if you guys have ever had a gallstone. It's somewhat on par with a kidney stone in terms of like, it freaking hurts. I'm not getting a massage. Like, this is my life right now. I'm home passing a gallstone. All right. Does anybody have any questions over anything we've gone over so far tonight? You know, when you mumble, I can't understand a word you're saying.
Something you brought up at the end of gallstones versus kidney stones, are they pretty much the same thing, just in different locations?
So functionally speaking, yes, same story is going on. You've got hard mineral crystals forming where they should not be forming, and they get stuck inside of fragile tubes. And now the body is painfully trying to push the stone through a tube that's way too small for the stone. The main difference is what the stones are made of, and obviously where they occur, right? Gallstones in the gallbladder, kidney stones in the kidney. Kidney stones are usually made of like calcium and phosphorus and minerals. Gallstones are usually made of cholesterol, which is fats. But the thrust of what is going on, yes, is the same. You've got little hard crystals where there shouldn't be, and they got to go through a tube, and it really hurts. Any other questions?
Yeah, when did you say we should take that other test?
So this week we're doing digestive. Next week we're doing endocrine, and the quiz covers endocrine. So I put that one off until next week. So this week there is no quiz.
Okay.
Dave, did
All
you
right.
get the message that I'm not going to be there next week?
I believe I did. Did I
I'm
respond to you?
No, but I'm having knee surgery, so I won't
Well,
be here.
that's no fun.
I know.
You're not even skipping class for like a fun reason. No, I did not get that, but the lecture will be online.
Okay.
That won't be a problem. I hope your surgery goes well. I wish you a speedy and uneventful recovery,
Thank you.
but have a better reason to skip class next time.
I
Boo.
know.
Surgery, boo.
This is a good thing, though. This is my third one, and my quadricep, there's a disruption in my quadricep tendon. So the tendon and the muscle aren't even attached to each other. And that was from surgery at OHSU. So it'll be my second corrective surgery, and it's with a really good surgeon. So I'm pretty excited about it.
I really hope this one goes better than the first two. My
I think
gosh.
I think it will. I know other people that have been to him too that have been really happy.
Good. Good. I wish you nothing but the best and a
told-
good recovery.
He told me he's confident that he can fix it. So I like that too.
Good. I like the confidence. I
Yeah.
like the confidence. Awesome. Yeah, no, that won't be a problem.
Okay.
Questions, anybody else? If not, let's take 10 minutes. We'll go take a break. We'll come back. Sound good? Sound good.
Are you good to turn off the recording?
No, I just leave the 10 minutes recording.
Okay.
Just mute yourself. Yep. All right, everybody, we are back. So, no one came up with any questions while over the break? Nothing to ask? All right, well, I have some questions then. Which condition that we talked about did not involve structural changes to the GI tract?
Irritable bowel syndrome.
Irritable bowel syndrome. Very good. Very good. 10 points to Gryffindor. Jaundice is caused by the accumulation of heavily pigmented bilirubin in the bloodstream. What is its most usual cause?
Liver failure.
Liver failure. When you see jaundice, I usually, first thing, I think liver. Next up, GI inflammation due to a viral infection or food poisoning or food sensitivities. Which condition are we describing?
Gastroenteritis.
Gastroenteritis. A condition involving chronic damage from repeated exposure to digestive juices.
GERD.
GERD. Very GERD. The small intestine contains small finger-like projections covering the internal walls called
Villi.
villi. Villi or villi. Singular, villus. What is the most common symptom with gallstones?
Right upper quadrant pain. No, wait. Nothing.
Nothing. Most people with gallstones don't have any complications with them. No symptoms, nothing. A shallow, continuous ulcer in the rectum and descending colon.
Ulcerative colitis.
Ulcerative colitis. Very good. Which of these is most accurate about peptic ulcers?
Second one,
Yeah,
believe-
you're right.
fluctuations between stress, bacterial infection, and medications.
I like that answer. Very good job. The crowding out of healthy hepatocytes by non-functioning scar tissue.
Cirrhosis.
Cirrhosis. Very good. A progressive, patchy inflammation along the inner lining of the GI tract. This is characteristic of
Crohn's disease.
Crohn's disease. Great job. All right, so between Hep A, Hep B, and Hep C, or several of them, which of these is the most dangerous?
C.
C.
Hep C. Which are best spread through shared bodily fluids?
All of them. Oh,
B
I
and
was
C.
thinking drink.
B and C. Hep B and Hep C are shared through body fluids. Which one spreads through contaminated food and water?
A.
That is Hep A. Which one is the reason that employees must wash hands before returning to work?
A.
That's Hep A. Which are vaccine preventable?
A and B.
And B.
A and B. And which one is not vaccine preventable?
C.
C.
By elimination.
There we go. Great job, you guys. Great job. Well, that was all I had. You guys don't ask questions. You don't talk none.
That's because you're such a good teacher and you present
Oh,
good
please.
information.
So please make sure you guys do the reading. Again, we covered the highlights, but there are a lot more conditions that are covered in the book. And again, quiz 3 is not due by next class. It's not. The quiz 3 will be due following the next class. So next class, we got to talk about endocrine disorders, and then we can do quiz 3. Good stuff.
Good stuff.
Yes.
Good
Good
stuff.
stuff. Well, we've been recording this, so this will be posted on, this meeting will be posted on Zoom before the end of the night, and shoot me an email if you guys have any questions.
Thank you.
Thanks, Dave.
Thank you.
My
Thank
pleasure.
you.
Have a
Have a
good
good
week.
evening.
Bye.
Casey, hang out for a sec.
Good night, everybody.
Hey, so let me stop recording real quick. Hold on.